This is Performance Improvement in Stroke Care. It's an education module that was created for post-alteplase TPA and/or mechanical thrombectomy monitoring in the ICU. The objectives for this project, Performance Improvement in Stroke, was to provide education related to the care of patients admitted to the ICU post-alteplase and/or mechanical thrombectomy. It's also to provide staff education related to documentation strategies aimed at improving compliance of post-alteplase TPA and/or mechanical thrombectomy assessments in the ICU. Just a little information about IV alteplase TPA. It's tissue plasminogen activator, and basically it's an FDA-approved clot-busting medication for acute ischemic stroke. It's approved for symptom onset greater than 3 hours, and then it was extended also to can treat patients up to 4.5 hours of last known normal. This has been the only treatment for stroke since 1996 when it was released. It's a protein involved in the breakdown of blood clots enzyme. It catalyzes the conversion of plasminogen to plasmin, which is a major enzyme responsible for clot breakdown. Because it works on the clotting system, IV TPA is also clinically used to treat the patients for suffering from ischemic stroke. Just remember that it is time dependent, and the assessments post-TPA are ordered assessments. They've been around for 20 years. They've not changed. Typically involves the blood pressure management, also neurological checks, and with the advent of mechanical thrombectomy that was released in 2015, there's growing management, just like a patient who has received cardiac catheterization. So there's some time parameters that are associated with all of these assessments post-TPA. Dissolving the clot and introducing blood back into the ischemic area decreases the area of damaged tissue and improves the chance of a more meaningful recovery. It works really well on small influnar infarcts deep within the brain. Mechanical thrombectomy works a little bit better for the ones that are more proximal in the internal carotid artery and the first part of the artery in the brain, the middle cerebral artery. In the next few slides, we're going to talk a little bit about the assessment of a patient during and post IV alteplase and our mechanical thrombectomy. Most of the time, by the time they get to the ICU, they're already through their Q15-minute neurochecks and blood pressure management during that time. But just in the slide right here, these are ordered assessments. Vitals and neuro assessments should be Q15 minutes times 2 hours, Q30 minutes times 6 hours, and Q1 hour times 16 hours. These are all ordered assessments within the order, and the screenshot below kind of shows you where to find those. Now, I want you to note, though, that this also says post-alteplase and/or mechanical thrombectomy. When mechanical thrombectomy was approved by the FDA with the invention of these stent retrieval devices, the management of the blood pressure and the neurochecks were basically what they did was they defaulted to the post-TPA. There's been no evidence or science to show less assessments would work better for patients who are admitted who don't get TPA. But in the meantime, this is what we go by, and this is what all of Dignity Health uses. So we default to the post-TPA management. We did create order sets, Dr. Mustafa and I, and we shared them with all the intensivists. In the order sets, as you see on the very top, it says status post TPA and/or mechanical thrombectomy ICU admission order. So those are the order sets, and all the intensivists have been educated on to use these order sets. This is what you should be looking for when you first see your patient arrive into the ICU, and from there on you should be able to follow these orders. They're right in the order sets. Assessment of the patient during post-mechanical thrombectomy also includes an assessment of the sheath site and pulses for post-mechanical thrombectomy patients. Groin assessment frequencies are found in the interventional radiology post-procedure order set. So you should look for those order sets when you first get your patient. The stroke admission order and the interventional radiology post-procedure order should be in your order sets upon admission to the ICU. Potential complications of IV TPA therapy and/or mechanical thrombectomy are signs and symptoms of intracranial hemorrhage. So we want to monitor for those very closely. Any change of level of consciousness, neurological deterioration, any new onset of acute headache, acute hypertension, acute nausea and vomiting should be investigated and notify the physician immediately. Also, one of the side effects of TPA is angioedema. This is something that a surveyor will ask you. They're going to ask you, what do you do if a patient shows any of these signs and symptoms? And and they're still getting the TPA, and the answer to that question is that you should want to stop the TPA, you want to notify the physician, and most times you're going to get a stat CT of the head to evaluate for intracranial hemorrhage. We want to be able to access neurosurgery if needed immediately. Blood pressure monitoring after TPA, there are standard blood pressure parameters that are set within the order sets. I want to keep the blood pressure less than 180 over 105 in most cases after TPA. And the reason for that is that TPA predisposes patients. There is a slight chance of bleeding, and what we don't want them to do is have a hemorrhagic transformation as a result of hypertension. So make sure you check your PRN medications and give them accordingly as ordered. And status post mechanical thrombectomy also, those parameters, BP parameters, they might be a little lower. So the interventional neurologist will communicate those blood pressure parameters, and it really depends on whether or not they had a successful thrombectomy or not. If they didn't have a successful thrombectomy, most of the time they default to the 180 over 105, but if it was successful, what you're going to get is a bunch of new blood rushing into the ischemic area. And what they don't want that to do, that could predispose the patient for hemorrhagic transformation also. So what they usually do is order the blood pressure in the 160s. These should be reflected in the orders. So make sure you check your blood pressure parameters after thrombectomy, because they may be a little different. We at Mercy Medical Center, we are a primary stroke center, and part of being a primary stroke center is that we look at quality metrics associated with our stroke program. One of the metrics we look at are documentation compliance of assessments after TPA, and what we noticed was that we were only 43% compliant with our documentation. So in our current state, the way it was assessments were located in different areas in the AHR, leading to challenges in compliance of ordered assessments and to confusion of what neuroassessments are required to meet the documentation standards. When you create that stuff, your compliance level could be low. So as the improvement, basically a test of change, the corporate work group got together, and we used to use paper flow charts, but we wanted to keep everything in the EHR, so we developed a stroke neurological assessment band that allows us to document all of our required assessments, our vital signs, our neuro checks, and our sheath assessments, to be documented in one place. The hope is, or the aim for this, is to improve compliance of the documented assessments, make it easier for the workflow of the nurses so they can get those assessments, and basically what this will hopefully do is translate into better patient care and improved safety for these patients who are status post intervention. So the next few slides kind of describes our documentation process. And what you can see here is it all begins with an order. So make sure the orders are in. If they're not, sometimes the patient will come up and the intensivist is busy doing something, and he won't be able to put these admission orders in right away. Usually the groin management orders are in if they had a mechanical thrombectomy, but if they just come in from the ER status post TPA, sometimes those admission orders aren't in there. What you can do is you can initiate the stroke quality measures, and it's a pre-checked order usually within the order set. If you have not got those order sets in there, you can initiate that order, and what that will do is it fires a task to the activities and interventions of the care compass. So when accessing the activities and intervention, the stroke neurological assessment band, you're going to click on that band. Sometimes it's confusing, so you'll see neurological assessment, but the one you want to use for post-TPA and assessments and mechanical thrombectomy assessments is the stroke neurological assessment band, located in the activities interventions section. Under continuous task, you may have to scroll all the way down to the bottom because it is a continuous task. Regular tasks go away once they're complete, but this lives down at the bottom as all other continuous tasks do. This slide gives you a screenshot of the Care Compass view. Note that you click on PRN continuous and the stroke quality measure stroke neurological band will live in there. Once you open it, it'll allow you to document your vital signs, your neuro checks, and your groin management all in the same spot. For patients who receive mechanical thrombectomy, the pulses and groin assessments are documented in the sheath dynamic group. Interventional radiology opens up this group when they place the line, so you would go to this section to document your sheath site conditions, your dressings, your drainage, and your pulse checks. Make sure that you report any changes immediately. A cold foot could be a problem, a complication. maybe the sheath plug became dislodged, it warrants a rapid evaluation by the vascular surgeon or the intensivist to make decisions on whether or not it needs to be treated or not. So just make sure you pay attention to those. I want to thank you all for all the care you give for our post-stroke and post-mechanical thrombectomy patients. It's my hope that this education opportunity will help improve the compliance of the documentation standards for post-TPA and post-mechanical thrombectomy. Following this presentation will be a demonstration. It was created by Candice Davey from the Clinical Informatics team. This will show you the specific on how to get around and navigate through the process of the documentation standards, and hopefully clarify any confusion that you may have about the neurological assessment that's required for post-TPA, post-mechanical thrombectomy patients.
As Kevin mentioned previously, the Stroke Quality Measures Order will fire a task for the stroke neurological assessment. You can either retrieve the task from Activities and Interventions or from your Care Compass. If you double-click on the task, it will take you into iView so you could document your stroke vitals, your neuro assessment, and just a point of clarification, you can use within defined limits or within defined limits except, but you do want to make sure you know what you're charting to. For the most part, for a stroke patient, you probably won't be using within defined limits in the neuro assessment. However, you more than likely will be using within defined limits except and chart your exceptions. Just to make sure you know what within defined limits means. If you don't know, all you need to do is left click on the blue text and you'll be able to see here is the definition for an adult neuro within defined limits. In addition, you can also document on your sheaths group. You would add the dynamic group by clicking in the graph just as you do a peripheral IV or a Foley catheter. Once you add that location, you can document your assessment findings from there. Make sure you document the assessment, the site condition, and you'll also notice that there's a new field for post-cath pulse check. And make sure you also document any other relevant information for that sheath assessment. As you can see, if you use your task list from Activities and Interventions or from Care Compass, it takes you exactly to where you need to go in iView, and you could document everything in one fell swoop. Lastly, it will show as a continuous task, so you could document it throughout the day from the task list, and it will not go away. For any questions, you can always call Kevin Baird in the stroke department, or you can call your local CI team at extension 2763.